So I'd like to kick off the primary care stream and welcome you to session 1, which is called Food is Fuel, Common Nutritional and Growth Challenges in Childhood with Dr. Kathleen McGrath. And what I'd like to do is just thank our sponsors. Dorovich is sponsoring this session for us today. As you would have seen for people here, we've got some sponsors booths outside. And also for our people online, you can go and look at the sponsors booth in the online session as well. So go and have a look there, and there is a prize for people who gather a stamp from each of our sponsors today. But we really can't do events such as this without our generous sponsors, so thank you very much. I'd also now like to share with you the health pathways relevant to this session. This is something very close to my heart. This is the work that my team and I do, is keep these up to date. So we've got some great content on health pathways that you can refer to relevant to this topic. We will have 5 minutes at the end of the session, roughly, for Q&A, so that's pretty tight. We'll try to get to as many questions as we can. For those in the room, we'll have a mic. Wait till the mic comes to you so that the people online can hear, and we'll also take some questions from online, so feel free to type those in whenever you like for our online crew, and you can vote up the ones that you're most interested in hearing about. I'd now like to welcome Dr. McGrath. So Kathleen McGrath is a paediatric gastroenterologist at the Royal Children's Hospital. She undertook her RACP training at the RCH in Melbourne, and with further post-fellowship gastroenterology training focused on intestinal failure and clinical nutrition at Birmingham Children's Hospital in the UK. She specialises in all areas of gastrointestinal and liver disease in infants and children, and has a special interest in the management of intestinal failure, complex nutritional problems, and food allergies. So welcome, Dr. McGrath, and I'll now hand over to you.
Thank you. So thank you for asking me to come and talk about this. I've got no relevant disclosures. So I think that growth and nutrition in children is an absolutely core and essential topic, and really is kind of paramount to anyone who works with children in terms of health professionals. So I've listed some learning objectives there for you, which will be on the slides. But essentially, in the next sort of 40 minutes or so, what I'd like to do is to just sort of do a focus on some of the key core aspects of growth and nutrition. So we'll talk a little bit about growth measurement and growth charts, and then move on to feeding assessment. And then I'm going to focus in with a bit of a deep dive on some of the common challenges, I guess, that you might come across in primary care. So particularly looking at selective eating and food allergies, with a focus on non-IgE related food allergies, and we'll use some case studies to supplement those. So when talking about growth in children, one of the key things is to really understand what normal growth is in order to know what's not normal. And I think it's really important for us to understand and to be able to reassure and explain to parents that one-off measurements really just reflect a child's size, and so growth is more a pattern over time, and it's really important to have those kind of previous measurements in order to be able to interpret the significance of a measurement. And we know that patterns of growth also change with age, and childhood is a broad sort of spectrum, and so it's really important to understand what we expect to happen at the different kind of age groups throughout childhood. So healthy children may grow, on percentile lines at the top or the bottom of the growth chart, and don't always follow one line, so there can be some fluctuation. And we know that growth is not necessarily a linear process. Now, in the early days, in early infancy, it does tend to be a more consistent and process with a kind of defined sort of expected weight gain each week. So we know that children in the first sort of 3 to 6 months of life do gain weight quite rapidly, and they gain weight at a more consistent rate. But if you can see in this table here, that tends to sort of plateau off a little bit in terms of the expected weight gain through the second half of the first year of life, and certainly they do still gain weight quite rapidly. But moving beyond that, we know that, in those preschool years, kids tend to grow in kind of spurts. And so they'll have periods of rapid growth where they might grow quite well. And then they have periods where there might be kind of apparent no growth. And parents can get quite concerned when you weigh your child and you weigh them about 3 weeks later and they haven't put on any weight, because they're used to, particularly with their first child, that idea that, you're focused on that 150 grams a week or the 30 grams a day, particularly with premature infants or where there has been concerns in the first year of life. And it's really important to be able to reassure them that we expect this kind of different pattern the older that they get. It's also really important to understand normal growth, but also understand what's normal in the context of our society. And the average birth weight in Australia is approximately 3.5 kilograms, and we know that the majority of babies born will be between 2.5 and 4.5 kilograms. But there is a proportion of about 7% who are classified as low birth weight, which is less than 2.5 kilograms. And this graph here kind of represents where we are in terms of international data in terms of low birth weight infants. And you can see there that we fall sort of 19th in the world on the OECD countries, which is important and relevant to kind of bigger picture health implications, because we know that low birth weight can be associated with health risks later on. And what about in older childhood? What are the kind of key patterns that we need to know about? So I think we're all familiar that overweight and obesity is a key issue in childhood, and I'm sure you've had sort of topics around that previously, so I'm not going to talk too much on that today. But what's important to note, I guess, is that even though these rates are quite high and approximately a quarter of children fall into this category, it's been stable since the early sort of 2000s. So I think that's nice to know that we've sort of plateaued out, and that isn't kind of a ongoing increasing trend. What's relevant though is to note that there are particular risk factors for overweight and obesity in children, and we know that from this national data that regional and remote children tend to have a higher rate of overweight and obesity compared to city-based children, that children from one-parent families have a higher rate, and also children with neurodisability compared to no disability do have a higher rate of obesity and overweight, and certainly that's something that we see quite commonly in our practice. So in terms of some basic principles around growth, and I'm sure that many of you know most of this, so it's just kind of maybe revision for some of you, but I like to think of it as the key kind of 4 A's. So in terms of assessing growth, we need the appropriate equipment. So for infants, you need to have an appropriate kind of, line scales, you need to have the infantometer, and you need to have a tape measure in order to be able to do their head circumference. And for older kids, you need to have an appropriately set up stadiometer and either a standing or a chair scales. Accuracy is key, and part of this is not only things like obviously weighing a child bare or weighing children in very light clothing and trying to weigh them around the same time every day on the same scales, things like that. It's also really important to get your measurements right, and we know that up to half a centimetre on a head circumference can actually change a whole centile line and can make a big difference in terms of your interpretation. So with head circumference, you should obviously be measuring it a few times, so measuring it 3 times ideally, but accuracy is really, really important, and not to rush things. And when you've got a squirmy child in front of you, that can sometimes be quite difficult. So as I mentioned, getting adequate information is important, so it's got to be accurate, but it's also got to be adequate. And so for children less than 2, we need all 3 parameters really to make an assessment about their growth. So we need their weight, we need their length, and it's important to know that all the 0 to 2 growth charts are based on a recumbent length rather than on height. So even though you can use a height in an 18-month-old, it will differ a little bit to their line length, and head circumference should be measured in any child below 2 years of age. And then we move on to analysis, and I'm going to talk in a moment briefly about growth charts, but some of the other things that can be quite helpful are the BMI charts by age, as well as the weight for length in less than 2 years of age. So which growth charts should we use? Now, I know in practice sometimes with electronic systems and things like that, they already have one pre-put in and you're sort of obliged to have to use that. But what are the Australian recommendations? So there's 2 main options: the World Health Organisation growth charts and the CDC growth charts. And I think it's kind of nice to just understand the context of where these came from. before we talk about the recommendations. So the World Health Organization growth charts were created from 6 different countries where they looked at infants over a longitudinal period of time, and these were healthy, breastfed infants growing in optimal conditions. So this is ideal, this is what we want, okay? And it spanned both the US as well as South America and Asia, so it's got, and a European country, Norway, so it's got quite a broad representation. So this is seen as countries, of ideal growth really, and countries where breastfeeding as the norm, this is what we expect kids to do. And they measured them 21 times in the first 2 years of life, so they measured them quite closely. Compared to the CDC growth charts, which were created as a snapshot. So if you go back to that first slide that I talked about where you're really measuring size, what they did is they went out in the USA and they measured a whole heap of kids once. And they only had a really small proportion of kids that were young, so it only a very small of 0 to 2, and a high proportion of formula-fed infants. The benefits were, though, however, that they included, accurate representation of what's actually really out there in society, but in America. And so for all these reasons, the NHMRC recommendations in Australia are to use the WHO growth charts from birth to 2 years, and that's because this is, breastfeeding is obviously the recommended modality of feeding in early infancy, and this is for all ethnic groups. And CDC growth charts should be used from 2 to 18 years of age, with some special growth charts to be used in prematurity until you reach the corrected age. So what kind of trends do we worry about, and what do growth charts tell us? Well, poor growth is something that we look for, and this is, rather than the terms of failure to thrive, I think there's a tendency to move more away to language that might not be sort of so prone to kind of, upsetting parents or making them feel like they've failed. And so poor growth is how I like to term it. And this is really like looking at a trend where you've got weight or height tracking downwards on growth charts. Overweight is classified as a BMI greater than the 85th centile on the CDC BMI chart, and obesity is classified greater than 95th centile on the CDC chart. And high weight for length is the equivalent that we talk about of obesity or overweight in children who are less than 2, and this is greater than the 98th centile. And just a few key things to note from these examples here. So obviously the CDC charts have more lines on them than the WHO growth charts, and so a really important period of time where you can kind of get a little bit muddled, or parents may get extra concerned because they suddenly jump up a centile line, is between that sort of 2 to 3 year age mark. And so it's really important then again to be able to understand this and educate parents around why they might have been on this growth centile and then suddenly now we're saying on this line. So I guess in terms of primary care and what you might see and when you might watch it versus when we might refer, it comes down to not just the growth, it's about the child and their context. So where you've got a well child with a weight or height less than the 3rd centile, look, it may be appropriate to just watch them, okay, and to look for red flags, okay, because there are some children who are well, who will track along there, who just grow in that area, and that's their genetic potential, and doing things like mid-parental height and stuff can add you extra information, but you need to make a proper assessment. You don't just go from the growth. However, if you have unexplained weight loss, or ongoing weight issues following an current infection where they don't regain that weight and get back to their previous centile, or they've just plateaued out, these are kind of the situations where you may want to instigate some basic management, but also consider referral to either a specialist or allied health input is often the key thing really in these situations. So a very brief overview of growth, but I guess some of the key messages are this is a sensitive area and it can be a really area fraught with anxiety for parents. I think using growth charts as a tool is very helpful, and to be able to explain to parents what they mean and what patterns of growth kind of refer, and to use them as an illustration. We know though that growth charts, it's not just about the growth chart, it's about the context, and you need to consider the child, which we'll talk about in a little bit more detail in a minute in terms of how you might make an assessment of relevant information. And in primary care, I think that measuring growth regularly can also, reassure parents a lot of the time that their child's growing well. So a lot of the time parents may be concerned, like I said, because they're not gaining weight, when they're 4 years old for a few months, but that may actually be okay if you then plot them on the charts and they're trending okay. So I'm going to move on to talk a little bit about what I like to call feeding assessment, and this sort of takes the place, I guess, of what people might refer to as a dietary history. And I think it's a nicer term because feeding in children is not just about the diet, it's not just about what they eat, it's way more complex than that, as most of you know. And feeding is a very learnt process, so it parallels a lot of other developmental spheres for children and how they go to develop. And so where they have developmental issues, this may then impact on their feeding progression. So as I said, it's more than just growth. It's about the adequacy of the diet, but it's also about their relationships with food and their behaviours related to food and the context that all of this falls into and the impact that that has on the family and the family environment, and that can be huge. So we'll go through in a minute how do you take a history related to a feeding assessment, but always observe if there's opportunity. And most of the time, a lot of the time, kids are snacking and parents are giving them snack to be quiet while they're in the room with you. And these are key observational opportunities where you can actually observe that interaction between the parent and the child. You can observe the interaction between the child and what they're eating. And sometimes parents will have videos as well. That's another really useful tool. And it's really important to be able to obtain information without passing opinion or judgment. So you need to be very objective when you're doing this because it's a very kind of anxiety-provoking situation a lot of the time for parents and families. So a feeding history should incorporate lots of different aspects. So we talk about, I like to think of it as a few sort of subheadings, most of which begin with W, but when do we eat? Okay, when's the child eating? What's their pattern of eating? Are they kind of eating meals and snacks, or are they just sort of grazing through the day? And what's the kind of weight that's put on their hunger and satiety cues by the parents, or are they feeding according to a schedule of what the parent wants? So what's that kind of dynamic? When are they eating through the day? What are they eating, I think, is obviously very information that we're all used to getting because, you know, in adults as well, asking a dietary history is much more about the what. But in kids these days, it's really important to sort of probe and look for some key areas. So exclusions is a very common thing that comes across, dietary exclusions. And many of the times, by the time a kid comes to see me, they're already on lots of different exclusions that the parents have initiated, and I'm sure that's similar in primary care practice. And a lot of the time it comes from, you know, research the parents have sometimes done on the internet, or perhaps the parents' own practices in their own diet. And so exploring those exclusions and the basis for those is really important. In thinking about food and what kids eat, it's really important to look across the board at the diversity of what they eat in terms of different food groups, but then also within food groups. So do they eat vegetables? Yes, they eat vegetables. Okay, how many vegetables do they eat? Because if they just eat 2 vegetables but nothing else, that's sort of relevant to know, I guess, in terms of their overall kind of intake and looking for nutritional adequacy. Again, then that sometimes links in with sort of sensory aspects, or you might find kids have particular textural or kind of colour related sort of preferences, and so exploring this kind of stuff in terms of diversity of diet is really important. I like to ask about ultra-processed foods in terms of how often they're eating junk food, how often they're eating food that's sort of cooked, you know, those kind of questions, because I think that can be relevant. And then also asking about fluid as opposed to just food. So sometimes kids will have a predominant intake of soft drinks and juice, or older kids may be drinking energy drinks, and it's really important to work out, are they drinking water, are they not? And often for me this is because it links in a lot with their bowel habits and their overall kind of diversity in their diet. So how much is also really relevant in terms of, you know, both portion size but also the distribution between things. And this diagram here illustrates what I guess the basic principles are when we educate around a balanced diet, but also adequate portion sizing for kids who sort of need some support around weight management, is to really try and get the emphasis on about half the plate of being fruits or vegetables. So ideally vegetables, but a lot of vegetables are actually fruits. So I think that's why this uses it as that. And then limiting, I guess, that balance between protein and grains or carbohydrate source in the diet. So then other things to think about are where is the child eating? So do they eat kind of, alone? And is there a difference in how they eat at school versus at home, or at childcare as well, particularly with younger kids versus at home? And with who do they eat? Are their family meal times? Is the kid eating by themselves? And then finally, it's really important, obviously, to think about challenges or concerns. So are there any, and this is where you look for your red flags, which we'll talk about a little bit more in a bit more in detail. So feeding assessment is this over kind of arched sort of, context of what food is and what eating is for this child in their environment, rather than just thinking about diet. It's really important to think about not only what they're eating, but sort of how much they're eating and how that is taking place into the social context for the family. And we must also think about screening for organic concerns. And like I said again, with respect to growth, it's really important to have a non-judgmental approach. So one of the key challenges I think that comes up quite often in feeding and eating for children and can be a nutritional concern is selective eating. So I'm going to just briefly present a case study and then we'll talk a little bit about this area. So a 20-month-old boy presents with his parents concerned about fussy eating. So he's a previously well child, only child for the parents, and he's got normal development and his growth's tracking really well. So he was breastfed for 4 months and then transitioned to formula via a bottle and had solids introduced about 6 months of age. So all pretty stock standard, kind of no red flags there. He had an episode of severe gastroenteritis at 9 months of age and was admitted for nasogastric rehydration at that stage. And so sort of since then and currently he has a fairly limited variety of foods, and the parents are quite concerned about this. So he really only likes to eat mashed potato, yoghurt, Wheat Bix, fruit purees. So he doesn't really explore much beyond that in terms of texture or food variety. And most of the time he's being spoon-fed by his parents, who are getting increasingly frustrated at this situation. And he likes to drink his bottles a couple of times a day still, 4 to 5 times a day. So selective eating is a spectrum, and we know that, again, like as I said sort of before, that feeding behaviours tend to parallel normal development. So we know that in normal feeding development, typical feeding development, there are times where kids have problematic behaviours. And so it's not so much the behaviour that the children are having, but it's the impact that it has on the family and on that child in terms of complications that defines whether or not it's a typical feeding developmental behaviour or whether it becomes a feeding disorder, okay? And this is a whole spectrum. And so when you're assessing, you need to kind of ask about what the behaviour is, but then you also need to explore what the impact is that it's having on both the child and the family. And there's a nice definition, I guess, of paediatric feeding disorders that I've given there that was in a paper published a couple of years ago in Journal of Paediatrics, Gastroenterology and Nutrition. And so again, going back to that point that I talked about before, if a child presents with selective eating, it's really important to make this careful feeding assessment, not just asking about what they're eating, but to asking how they're eating, where they're eating, what the problems are. And some of those kind of red flags or concerning features that I mentioned before when we're screening for organic illness, this is when this is really important that you ask about these. And these might include things that you need to obviously look at the growth and to check that that's adequate and whether there's any implications for growth, because that would be a complication that might make you worry that this is more of a disorder rather than a typical feeding developmental behaviour. Asking about adequacy of diet can give you clues to micronutrient deficiencies, but obviously doing your clinical assessment and then making sure there's no signs of pallor or iron deficiency or other micronutrient deficiencies. And then asking for other kind of key things that might sway you to think that there might be something medical underlying. So, for example, indicators of malabsorption, body image issues in an older teenager, mood, attitudes or behaviours that seem a little bit unusual around food and eating. I think having a good grasp of the kid's developmental level is really important because, as I said before, we know that children who have neurodiversity or children who have neurodisability are at much greater risk of feeding disorders as opposed to it being a transient feeding behaviour. And interestingly enough, I think that, as I'm sure many of you have come across, often food and eating can be one of the things that really prompts that initial time where parents come with their concerns, and that can go on and lead to a diagnosis. And so being really sensitive in those contexts of asking about questions about development without, in a very non-judgmental way is really important to engage the families, because you may then need to think, hang on, you know what, I'm worried about this child and I'm going to refer them off to see an OT or a speech pathologist to get an assessment, because I think that there might be a concern about possible autism or something like that that hasn't been picked up. Just briefly, a couple of the key things. So eating disorders, obviously, something that can come up, and it's important to ask some questions around those. And then there's this whole new area of UFID, which is quite, common in our practice that we see. And this is really where you've got an eating or feeding disturbance that results in a failure to meet their nutritional requirements and is associated with complications without a real clear underlying medical or mental condition that explains it. And it's controversial in the literature how this differs from feeding disorders and ARFID, and I think it's a bit of a grey zone and will be ongoing, sort of defined depending on who you're asking. So again, going back to management, think about how this is impacting on the child. Is it pervasive across the environments? Is it persistent? Is there problematic kind of consequences? And where you think that, no, actually not, it seems like it's a well kid, this is just a bit of a phase, it's not really causing complications or impacts, then that's appropriate to do simple interventions and follow up and make sure you've got a monitoring plan in place and supporting and reassuring. Where you think that, it's a problematic behaviour that's got complications and we're more worried about this being a feeding difficulty, that's the time to probably think about referring on, particularly to allied health initially for an assessment. And some of the things that we can do in terms of, management in these situations include reassurance. Defining roles can be a really helpful way for parents to know how to approach this. And so I really like this kind of management approach where you explain to the parents, actually, you know what, your job is to decide what you're going to offer the kid, and you're in charge of offering and providing the opportunities for them to eat, okay? You can't control how much they're going to eat. That's what the child decides, because they're the ones that deciding whether they're hungry or whether they do and don't want to eat it. But giving parents that, you decide when you offer things, you decide what you're going to offer them, so that you're giving them some education around healthy food options and things, and let the child decide if and when they want to eat. And if it is just a typical feeding developmental problem and the child's got no growth concerns, it's okay that they might have days where they eat a bit less, but it's really important that parents try and tune into those kind of hunger satiety cues with the kid. So going back to the case study that I mentioned, some of the key issues in this case were that obviously common excessive milk intake and filling up in a toddler, and it's important to try and counteract that. Often kids get into a habit with feeding behaviours or liking the bottle around this age, but this kid really, was a well kid, normal development, normal growth, no real red flags, did have an event that might have kind of given him some sort of initiative to have a bit of oral aversion or, discomfort around eating because he associates it with that nasogastric experience and having that. But there's no kind of real indicators at the moment you need to do anything else. And so you can give some simple advice about kind of reducing the milk intake, trying to get him to wean from the bottle, so it's transitioning him to being an older child, like going into that kinder kind of context. And allowing the parents to know that, often you need to try a number of times before kids will take things, and just giving a lot of reassurance. So like I said with selective eating, it's very, very common. It's a spectrum. It's important to look for red flags to suggest underlying concerns, but the important thing is not just to focus on the behaviour, but also assess whether there's an impact on the behaviour, and as part of that, growth is an important aspect. And really management involves that partnership between the child and the carer, and getting the parents to understand about feeding behaviours and to respect the child's sort of cues, and getting the child to sort of feel like they have some choice in the matter as well. So finally, I think in the last sort of five minutes or so, I will just talk about food allergy. And so very briefly, an 8-month-old girl presenting to ED with 1 to 2 hours of profuse vomiting, and she lives with her parents and her sister who's got some atopic conditions. And she's an otherwise fairly well girl, normal development, normal growth, and good eater, exclusively breastfeeding till 6 months of age. And she presents quite pale and floppy, and she's had a number of vomits, non-bilious, no blood, and not tolerating any oral intake in this period. But no other kind of signs to suggest any other intercurrent infection. And she was well until 2 hours ago, and then she just suddenly started vomiting. And when you go back and ask the history and probe, a couple of hours before the vomiting onset, she ate rice for the second time. And so she was diagnosed with something called food protein-induced enterocolitis, or FPIES, which some of you may have heard of. So this is this whole area of food allergy that we're seeing more and more of. And just to kind of, I guess, we all know that food allergy is an overreaction of the immune system to a certain food or a food component, and there's many different mechanisms as to why it might be increasing in prevalence. And I like that picture there of these kids playing mud pies back in the many years ago. But it's important to understand that there's different groups and there is overlap, and that's the complexity that we often see now. So IgE-mediated food allergies are the ones that we very commonly know about, where there's an immediate reaction, so it tends to occur within an hour. And this is a spectrum from anaphylaxis being the most severe, obviously, to mild kind of localised reactions, but and often can involve many different organ systems. So non-IgE mediated food allergies, however, tend to be delayed in their onset, and they're much more difficult to define in terms of an identifiable trigger at times, and it can be delayed for up to a couple of days, and these are mostly gastrointestinal responses. And then we have this third group of mixed IgE or cell-mediated food allergies, in which we see all of the eosinophilic gastrointestinal diseases that we see sometimes. But children can have food allergies from more than one group. And I think there's a session this afternoon on food allergy, which I'm sure is going to talk more about the IgE stuff. So I thought I would just quickly take you in a little dive into non-IgE food allergy. So FPIES, which we talked about just briefly before, so this tends to be a vomiting type reaction, okay? And its onset can often be in the first few months of life, particularly where the trigger is cow's milk or soy. However, sometimes the trigger is a solids food, and so it's something that doesn't come up until parents introduce their kids to sort of certain foods when they're starting to introduce solids. And the commonly kind of documented triggers in the literature are cow's milk and soy, which obviously will come up earlier typically, but rice, particularly egg and wheat. So these ones often won't come up until the child starts on solids. And the acute presentation, it's got two forms. The acute presentation tends to be a really bad stomach bug, but often without diarrhoea. And sometimes it takes a few episodes before someone triggers to think about this, because obviously you need to think about sepsis, you need to think about gastroenteritis, you need to think about urinary tract infections. So you need to think about those relevant differentials, and often parents won't think back to 2 hours ago and realise the association. So it's something to just keep in your head, but it's really important to exclude relevant differentials. And we know now that there's also this kind of more chronic picture of FPIES, which tends to be a pattern of more intermittent but progressive vomiting, where there's a sort of background low kind of level of exposure to this allergen, and the kids just a really refluxy baby, and it might be getting worse with time because you're sensitising them, but often this is much more tricky to pick up and to actually identify. Now, something that I'm sure GPs sort of fairly familiar with, because it's a fairly common presentation, is the baby with mucousy blood in the stools, and you can see from this picture here, often in a breastfed baby, the parents may report that they've got increasing mucus in their stools, and then they sort of just think, oh, I'm not quite sure about that, but then suddenly they start getting little bits of blood in the stool, and the parents get really, really worried and present. And the onset of this is typically around three months, but it can happen earlier, and it can also be a little bit delayed beyond that, but usually around that sort of 8 weeks to 3 months of age, with the primary triggers being cow's milk or soy. And these kids tend to be very well. And then the final kind of, I guess, main group of non-IgE mediated presentations, which is much, much more rarer than those two that I just spoke about, is food protein-induced enteropathy. And this is what used to be referred to as cow's milk sensitive enteropathy, and is a much more kind of trickier to pick up situation, and usually presents again in that first year of life, but not really with a clear trigger, and it's these kids tend to be more unwell with concerns around malabsorption, and often it may be triggered in the context of an infectious gastroenteritis, but it can also be difficult to kind of distinguish from a post-infectious enteritis, and so this tends to not really be identified until you get down the track and this kid's sort of got failure to thrive, or issues with their growth, and someone decides to put them on a different formula and suddenly they get better. So there's no real good tests to do with this, and we know that there's a limited kind of value of traditional allergy testing in non-IgE mediated reactions, and so the best sort of, I guess, diagnostic tests that we have are this high index of clinical suspicion. So actually knowing about these and thinking about these conditions is sort of really important, and then excluding important differentials, like I said, and doing an elimination diet, and then plus or minus a re-challenge is really the test of the diagnostic test. And most management lies around food elimination, and it's really important to counsel families and parents, though, that these allergies are usually outgrown, and so it's really kind of as the immune system and the gut is still developing in the few years of life, but generally these kids will outgrow these by sort of between 2 years of age and sort of school starting, depending on what literature you read, and then you can kind of give education and advice around re-challenging. So food allergies are very common, and there's a range of pathophysiological mechanisms, and diagnosis can be quite challenging with non-IgE mediated food allergy, and often dietitian and specialist input is needed. So I've just got up here a couple of resources that might be helpful or interesting for people that you may or may not know about in this area. So we recently did a clinical practice guideline on non-IgE mediated food allergies, which can be accessed where all the other CPGs are on the Children's Hospital website. Oh, sorry. And then the Education Hub is I guess, our multidisciplinary educational group through the Royal Children's Hospital, which has an online learning platform. And together with some allied health colleagues, I created modules for feeding development, and we've got one that's going to be processed soon of feeding difficulties, as well as paediatric growth and growth charts. They take about sort of 20 minutes, half an hour really to work through, and you just have to put in your details as a health professional, but you don't have to pay. They're free to access, but you just got to register because it's meant to be for health professionals as opposed to parents. And so they're accessible through the Children's Hospital website. And we also did a podcast on fussy eating, which is designed for parents, actually. But if you've got parents and you're really finding it, that they want to know more about normal kind of typical feeding behaviours and difficulties in toddlers, then the Raising Children website or the podcast might be helpful as a resource to steer them to. Thank you.
Thank you very much, Kathleen. That was very interesting, and I'm sure we'll have some questions now for Kathleen. So we might start with the room first. So if you've got something that you would like to ask, pop your hand up and Anne will come to you with a microphone. Any questions in the group? We might... We'll just wait for the mic so people online can hear. Thank you.
Just with behavioural eating, where you've got a child who just refuses to eat vegetables is the common thing that you... what sort of strategies or what other supports are there other than us sort of explaining that this is something that they'll have to look at ingenious ways of making their vegetables more appealing, and also stopping the other options not being available, the things that they tend to gravitate towards?
Yeah. Yeah, very common scenario. I think the first thing is to make sure that you don't have that concern that this is reflecting a sort of significant feeding disorder, so making sure that you've not got any red flags or growth concerns. But if you've got reassuring growth, there's no kind of concerns about underlying organic illness, the kid's development seems very appropriate, then a lot of it is reassurance. And I'm yet to find a child that doesn't eat any vegetable. So even things like potatoes and I guess, carrot, cucumber tend to be, you can usually find one. So what I tend to tell parents is to give them that vegetable every day, because then you know that they're getting a vegetable, and to continue to try and offer the other things, because it does take time, but it's really important, obviously, that not forcing and telling parents that, because they get very frustrated, but to offer it on the plate and to keep offering it, and for the rest of the family to keep eating other things, but to put it on a plate where they've got something also that they do like and do want to eat. A lot of parents use as well, chopping things up and putting them in bologneses and meatballs and grating vegetables, and so there's a lot of different ways you can prepare them rather than offering it directly. But I think you need to sort of keep offering directly as well, and not just hide it all in kind of baked stuff, because eventually often the child will get there. So I think it's important to work with what the child does like and to have that conversation, and find the one thing that they do like, and that's really good, and keep giving them that, but to keep offering the other things. And like I said before, my point about fruits and vegetables as well is, things with seeds are supposedly fruits rather than vegetables, and so a lot of the time there's a bit of overlap there in terms of they might be eating some things that, I sort of see fruits and vegetables as a big group.
Thank you for your presentation. Probably a little bit of a comment that there's probably a lot of work for a GP to do all of that assessment in their short time frame. So I'm just here, I'm a dietitian. I'd actually like to promote that we can assist with all of that assessment. We can do all of the topics sort of covered. So thinking of referring to your local community health centre, and particularly in Geelong, we've got a lot of very skilled dietitians that work and able to see paediatric clients for a low fee, but also thinking about your private practice dietitians that have a special interest in children, food, fussy eating and allergy. We do have a range in the region.
Yeah, absolutely. I think most community health centres do, and we usually will often, parents can go and look it up and ring up and self-refer as well.
Thanks for your talk, Kathleen. I was wondering if you could give us some tips for optimal parent behaviours throughout childhood to introduce fussy food. So I'm thinking I've got sort of 3 or 4 families where the child, even when they were breastfed, would wait until the mother came home from work, would refuse a bottle, and then these children still at 10, the parents are still doing work, so they're doing a lot of this, offering multiple foods, hiding vegetables. Is there sort of 3 top tips around trying to get these children to improve their behaviour? Because it just seems like it's been 10 years worth of work for these parents, and I'm not quite sure if intervening in some other way might have been helpful.
Yeah, I think allied health involvement is key. That's, I think, where you make gain is getting allied health input, and I think sometimes just for the families to be able to see someone once a month and sort of step through, because it's slow and it's hard work and life is busy and it gets in the way, and I think that's all the challenges. Probably even harder when you get to a 10-year-old and you can't really backstep a lot of time. But I think, allied health referral early on, usually, I don't know if there's much limitation in terms of access to allied health in the community, but I think the nice thing about feeding difficulties is that they do cross that spectrum between OTs, speech, dietitians, and most people who are, a lot of them will be able to kind of do that whole assessment. So you've got a broad range of allied health people to consider involving as well. It's not just one area.
Thank you for this presentation. It's been great. I want to share something from lived experience because I have 4 children, 2 with serious allergies with milk and other foods. And the dietitian we had all those years ago came up with a wonderful plan, which my own daughters and grandchildren are using. And that was once a week, take the children down to the fruit, whether it was a market or the fruit shop, and let them choose one new thing to try a week. And the whole family would try that. And they may not all like it, but over the years we grew the variety of foods that they were eating and they were accepting. It just made so much of a difference, and it's still working as the generations go. So I just thank that dietitian that suggested that out of sheer frustration when we just didn't know what was going to work, and it did work.
Yeah, no, absolutely. And I think that's that principle of what we call graded introduction. So it's just putting it there and then sort of, having the family taking it on board really kind of gives that role modelling aspect. And what you find in talking parents through is sometimes the first time they might just look at it, and then if you keep sort of giving that opportunity, then they might sort of touch it and have a taste. And things like, you don't need to eat it all, you just try it, and things like that. The language is really important.
Well, that looks like we've come to the end of our questions. Just checking online, I think we're okay. So thank you, everybody, and thank you very much, Kathleen, for your presentation. That was really terrific.